second version of important investigations. As investigations have been shared by participants, they are not my choice, and they're all good suggestions. And I am thankful to them for those who suggested. So let's begin our 155th webinar. Miscellaneous lab test, indication, interpretation, and management. Last webinar, I had said that next time we'll cover calcium. Calcium is one test which we don't do very often because we don't think beyond that. We just are satisfied by prescribing a calcium to patients, which is of course right, which should be given. Serum calcium, the most abundant cation found in the human body. And we all know that calcium plays a vital role in multiple metabolic processes, not only teeth and bones. It is very important for nerve transmission, important for several enzyme activities that go on in various metabolisms. Myocardial contractility, calcium is required. Process of coagulation also requires calcium. And a lot of other cellular functions require calcium. The metabolisms per se require calcium. Most of the calcium is found in bones as calcium phosphate, while a small percentage is found in the cells and extracellular fluid. In the body, we have calcium which exists in two forms: total calcium, circulating calcium, and ionic calcium. What is the difference? When should you ask for ionic? When should you ask for total? Although tests can be done for both, but you have to specify. If you write advise serum calcium, they will do total circulating calcium. If you advise ionic calcium, they will do ionic calcium. Now, most of the reports, I would say almost 100% reports we see of calcium are wrong. Why? Because calcium test is only test where the blood is to be collected from a vein without tying a tourniquet or without asking the person to clench, because this will push calcium into the cells and you may get a false reading. And we know calcium is never tested alone. It is tested as a part of packages, and then you will get a reading which is normal. Patient may actually be hypocalcemic. Only the ionized calcium reflects the biologically active form of calcium in the body. It's like I was explaining to a patient, they were asking, why should we do FT3, FT4, TSH? Why not T3, T4? Because it is cheaper. So I was telling them that FT3, FT4 is the free hormone available for action in the body. It's like in our house, we have plenty of water, but only some water is drinking water. Similarly, ionic form or ionized calcium is the only form which is biologically active and is going to be available for all the functions that it is required. Just like FT3, FT4, TSH. So I will take a diversion and I will cover this because we in my clinic actually refuse to see T3, T4, TSH. We insist on FT3, FT4, TSH. So difference between T3, T4 and FT3, FT4. T3, T4, TSH is a thyroid hormone test. Everybody knows that measures the level of thyroid hormones bound to thyroxine binding globulin in serum. These are bound hormones. They are not active hormones. FT3, FT4, TSH is a test that measures the level of hormones unbound to globulin freely available for effect in the system. Now, you may have 1,000 liters of water in your house for bathing, for going to the toilet, using in the commode, washing clothes. But if you don't have enough drinking water for the whole family, then you are in hypo water. So understand now why we should always ask for FT3, FT4, TSH. This test measures the amount of free thyroxine and free triiodothyronine or T3 or T4 circulating in the blood that is available for cells to act upon. So now we come back to serum calcium versus ionic calcium. In the serum, 45% of calcium is bound to proteins, whereas 40 to 45% exist as free or ionized calcium or the active form, while 10 to 15% is bound to anions like phosphates and citrate. Now comes the importance where we should do ionic, where we should do total. Since systemic acidosis decreases calcium binding to albumin, serum levels, albumin increasing serum levels. So acidosis decreases binding, you will have higher serum levels. Alkalosis will cause opposite effect, increase the binding and decrease calcium levels. In such a case, we should ask for ionic calcium. The most reliable way of assessing calcium status in suspected acid-base disturbance, parathyroid disorders, or malignancies is to measure ionized calcium density. You may wonder why we are talking of malignancy. Because when we talk of hypercalcemia, malignancies are the commonest cause for hypercalcemia after parathyroid hormone disorders. How do we suspect clinically metabolic acidosis or alkalosis? You are suspecting a patient of asthma with high fever and much more breathless than the wheezing will show is likely to be in acidosis. Or if arterial blood gases have been done and it is shown that patient is in acidosis or alkalosis, then total calcium is not required. Ionic calcium is the only answer. The normal serum calcium ranges from 8.8 milligram per dl to 10.8 milligram per dl without tourniquet, without clenching the fist. Concentrations are highest in neonates and infants, decrease during childhood and adolescent, and stabilize at adult values by 17 years of age. Mild hypercalcemia is 10.5 to 11.9 milligram per dl. Moderate hypercalcemia is 12 to 13.9 milligram per dl. And hypercalcemic crisis is 14 to 16. These patients will go into crisis. You may get ECG changes also. So how do you understand whether normal calcium is important or not? Let's look at the clinical features of both hypo and hyper. Severe hypocalcemia leads to tetany, everybody knows, obstetrician hand. convulsive seizures, especially in children. An infant getting a seizure, they immediately check blood glucose for hypoglycemia and serum calcium and magnesium. And cardiovascular, psychiatric, and a variety of ectodermal problems affecting the skin, sweat glands, hair, teeth, and nails. Hypercalcemia, on the other side, associated with soft tissue calcification, tubulointestinal nephropathy, anorexia, nausea, a spectrum of neurologic changes. One thing confusing here is both hypo and hyper will lead to altered sensorium, from headache to coma and ECG changes. Now, those of you who have ECG machine, what changes you will see? The ECG abnormalities that may occur are ST segment elevation, biphasic T waves, prominent U waves. But as I always say, we do not diagnose hypercalcemia from ECG. If we have a ST segment elevation, I will first rule out an infarct or acute coronary syndrome. Changes in T wave morphology, polarity, and amplitude appears with the development of hypercalcemia and disappears when the calcium levels normalize. What are the causes of hypocalcemia? Parathyroid hormone deficiency or parathormone deficiency, surgical removal. A patient of mine underwent a goiter surgery. It was huge, almost 4 kilos. I don't know why she was delaying, but when it started giving us stridor and dysphagia, they took a call. There was a fear of surgery. She was in a mid-level tertiary hospital. And on day 2, or rather later part of day 2 after surgery, she went into a convulsion and she had tetany posture. Calcium was checked. It was very low, almost 3 to 4. IV calcium gluconate was given. And by then, the histopathology report of the goiter had not come. When the report came, it was discovered that all 4 parathyroid glands had been removed along with goiter because it was so huge. Surgical removal, irradiation. You have a case of oral cancer which has been given radiation. Naturally, parathyroid hormone can get affected. And if there is a hypomagnesemia for some region, then you may get hypocalcemia. Vitamin D deficiency also leads to hypocalcemia. Dietary insufficiency. Then nephrotic syndrome and hepatobiliary disorders, chronic, also lead to vitamin D deficiency and then hypocalcemia. Anticonvulsive therapy, anti-epileptic drugs also lead to hypocalcemia via vitamin D deficiency. So, vitamin D deficiency, renal failure, hypophosphatemia. Vitamin D is not generally to be given or considered only when the patient is tired or has bone pains. Everyone knows Alka ma'am. We had done a study with Padma Shri Alka ma'am. We got sample from JJ hospital of almost 100 HIV patients, and all of them had vitamin D below 10. We did a similar study of around 50 patients of tuberculosis, where also vitamin D was found very low. So all these conditions, nephrotic syndrome, hepatobiliary disease, patient on anticonvulsive therapy, renal failure, chronic renal failure, and hypophosphatemia. Today, phosphorus is being tested for routine body checkups. then you have to check that and replenish that. Vitamin D, please remember, is a sunrise vitamin, and it also affects several processes, very important processes of the body. Then there's a condition called transient hypocalcemia, when massive transfusion has been given with acidic blood, rickets is being treated, or there is a osteoblastic metastasis. So that time you will have a transient hypocalcemia till that part is corrected. Then hyperparathyroidism or hyperthyroidism. Hyperthyroidism, around 20% patients will have mild to moderate hypercalcemia, sorry. Then hypothyroidism also may have hypercalcemia. So parathyroid is the main hormone which can make hypocalcemia or which can give patient hypercalcemia. Thiazide diuretics, metastatic bone disease, vitamin A or D excess. Today, our patients have got into a habit of taking vitamin D weekly for ages. One patient was given 3 injections by the doctor, and because she felt better, she kept taking every 2 weeks. Landed up with a vitamin D of 170. Sarcoidosis also has hypercalcemia, and malignancies, lymphomas, sarcomas, leukemias. Primary hyperparathyroidism, overactive parathyroid gland, and malignancy. 2% of all cancers are associated with hypercalcemia, account for 90% cases of hypercalcemia. So understand this, malignancies and primary hyperparathyroidism account for almost 90% cases of hypercalcemia. The main cause of hypercalcemia is an excess of parathyroid hormone or PTH, and PTH mediated causes include adenoma or hyperplasia of the parathyroid gland. Although more common in adults than in pediatric cases, renal carcinomas, leukemias, and lymphomas and rhabdomyosarcoma are associated with high calcium levels mediated by the action of parathormone related peptide. Let's not go into that much physiology, but these patients will develop hypercalcemia, and although an oncologist may be treating, you have to look out for hypercalcemia. I once asked an oncologist, he said, it's not my job to treat hypercalcemia, it's your job. There is some relationship between calcium and parathormone. Parathyroid hormone levels are mainly controlled by a feedback loop of calcium levels in our blood to our parathyroid gland. There's a feedback loop. I'll explain to you with a picture. Next slide. Low calcium levels stimulate parathyroid hormone release, whereas high calcium level suppress parathyroid hormone release. See this. Calcium and parathormone, there are 4 organs involved: parathyroid glands, intestines, kidney, and bones. And this down below the square, you see extracellular fluid calcium. Now, if you see as it becomes low, you see this negative mark. This acts upon parathyroid gland and causes the increase of parathormone, excess of parathormone, which works on the bone, which works on the kidney. Sorry. Let's see how does it work. Keep this image in mind. Parathyroid calcium feedback loop controls calcium homeostasis. 4 organs, as I said: parathyroid gland, intestine, kidney, and bones. A reduction in serum calcium stimulates parathormone release, which increases bone resorption, enhance renal calcium reabsorption, and stimulate renal conversion of 25-hydroxyvitamin D to active moiety 1,25-dihydroxyvitamin D, which will then enhance intestinal calcium absorption. So see this. Hypocalcemia in ECF will trigger parathormone, which works on bones and cause more calcium absorption. That calcium goes to extracellular fluid. It works on kidneys for direct increasing calcium reabsorption, and via kidney converting 25D vitamin D to 125, which also in turn causes calcium absorption in the intestine and thus increasing calcium levels when there is low calcium level. So this is the feedback loop between parathormone and calcium. Then we have calcium and phosphate. We know the calcium phosphate is major part of the bone. They are also critical to neuromuscular transmission and skeletal mineralization, formation of bones. The hemostasis of calcium and phosphate, critical organs involved are bones, parathyroid, GI tract, kidney, as we saw last time, as well as the hormones, parathormone, vitamin D, FGF3, fibroblast growth factor 23. Let's not get into that because that is not for our purpose. That is for an endocrinologist. Disorders of calcium, phosphate, and bony metabolism are among the most common diseases in endocrinology, other than diabetes and thyroid. Involves abnormalities in serum concentration, especially of calcium, abnormalities of bone. It causes bone abnormalities and abnormalities of major regulating organ system like parathyroid, kidney, and GI tract. The serum calcium concentration can be abnormally high, as in malignancy and primary hyperparathyroidism, or abnormally low in renal failure or hypoparathyroidism. The skeleton will have low density, either low density osteoporosis, osteomalacia at a young age, or high bone density, as in Paget disease of the bone, osteopetrosis. Osteopetrosis is reverse of osteoporosis. That is porous bone. This is stony bone. And other osteoclastic disorders, osteosclerotic disorders, where bones have become hardened. The GI tract shows low calcium absorption, as in malabsorptive syndromes, or high calcium absorption, as in vitamin D intoxication and milk alkali syndrome. So excess of any vitamin will disturb the calcium and phosphate metabolism. Kidneys can either under excrete calcium, as occurs in some hypercalcemic disorders, or over excrete calcium, as in some patients with stones. Patients with multiple renal calculi will be over excreting calcium. Then we come to phosphorus or phosphate. They may under excrete P4. I think I will let it go because this is not for us. It is for endocrinologists. Parathormone is now we have to check if you have a case of persistent hypocalcemia. You are ensuring patient takes milk, curd, and calcium supplement twice, and still it is hypocalcemia. You have to check parathormone, or if it is hypercalcemia, again check parathormone. So along with calcium test, it is used for diagnosing hyperparathyroidism, diagnosing hypoparathyroidism, Evaluate abnormal calcium level etiology. Why the calcium levels are low? Because we know now they go hand in hand. And monitor kidney disease, especially chronic kidney disease. To monitor, you have to do parathormone regularly, once in 6 months maybe. Coming to magnesium, again becoming very important nowadays. I have a collection center in my clinic, so we see a lot of patients today inquiring, today means lately, that do we need to be fasting for magnesium test. Again, another abundant mineral in the body is a cofactor in more than 300 enzyme systems that regulate diverse biochemical reactions. So calcium, magnesium affect multiple hundreds of systems, including protein synthesis, muscle and nerve function, muscle contractility, nerve conduction, blood glucose control, blood pressure regulation, production of energy, ATP, and oxidative phosphorylation. So we can list 300, but it's virtually everything, and even glycolysis. Glycolysis is important for blood glucose control. It contributes to structural development of bone and is required for synthesis of DNA, RNA, and antioxidant glutathione. So you need calcium for all of this. Deficiency of glutathione, commonest in practice we see hyperpigmented skin. And I have tried in some patients, it's difficult to get glutathione capsules, but then it gives good results. It also plays a role in active transport of calcium and potassium ions. So all these are linked. Calcium, potassium, phosphate, magnesium, and parathormone. So it's very important with calcium and potassium for impulse conduction, muscle contraction, and normal cardiac rhythm. Normal test results are generally in the range of 1.8 to 2.6 for adults and 1.7 to 2.1 for children. Now comes the significance that blood levels do not do justice to the magnesium stores. Serum levels have little correlation with total body magnesium level, as an adult body contains approximately 25 gram of magnesium. And what are we talking here? 1.7 to 2.1 milligram per deciliter. 50 to 60% is present in bones and most of the rest in soft tissues. So serum concentration is very low. Less than 1% of total magnesium is in serum and are very tightly controlled by kidneys. Homeostasis is largely controlled by kidney, which excrete about 120 milligram of magnesium into urine every day. If the magnesium levels in the body go down, this excretion stops or reduces. So that is why the kidney is the main regulator. Symptomatic magnesium deficiency due to low dietary intake in otherwise healthy people is uncommon. So if you have a low magnesium report, do not jump to the conclusion that this is giving weakness to patient. Please check, is it a good lab? Is it NABL accredited lab or what? Why it is uncommon? Because kidney limits the excretion. However, habitually low intake orally or excessive loss due to chronic alcoholism and or use of certain medications can lead to magnesium deficiency. So now you should give a chronic alcoholic magnesium supplements. Hypomagnesemia, which drugs cause it? Loop diuretics like furosemide and torsemide, and thiazide diuretics like hydrochlorothiazide and indapamide. So when you check serum electrolytes, might as well check magnesium also. Early signs of magnesium deficiency are vague. They're nothing specific. Loss of appetite, nausea, vomiting, fatigue, weakness. As magnesium deficiency worsens, numbness, tingling, muscle contractions, cramps, seizures, altered sensorium, personality changes, abnormal heart rhythms, arrhythmias, and coronary spasms can occur. Severe magnesium deficiency can result in hypocalcemia or hypokalemia because the homeostasis is disrupted. So you may not get symptoms of hypomagnesemia, you may get symptoms of hypocalcemia or hypokalemia. Supplements of magnesium are not available as magnesium alone. You may get some elements in Amazon shopping. These are 4 brands which have a decent amount of magnesium: Calcium Export, MGD3 Pharmed Company, Zincovit, and Maxirich. Those of you who want can take a snapshot of this. Magnesium content of select foods. So if you see now, pumpkin seeds roasted 1 ounce, that is 30 grams, has 156 milligram and still only 37% of daily need. So generally, diet is not very good source. 31 ounce of chia seeds people find difficult to eat, and 1 ounce of dry roasted almonds is like too much, almost 30-40 pieces. There was a request for anti-CCP and certain IgM, IgGs, not of dengue. So let's look at how immunity works. As soon as a foreign protein enters the body, the lymphocytes identify the protein, kind of fingerprint it, and determine if it belongs to the host or not. So their job is to identify this is self or this is not self. Whenever they discover a cell that seems threatening, they immediately begin countermeasures. It's like you are walking in a road and you see people running towards you with swords, you will start taking countermeasures. So this is a beta lymphocyte. This is an offending organism. It's a virus. It's actually HIV virus. Beta lymphocyte saw the virus and confused. This is not self. This is non-self. And this beta lymphocyte got converted to plasma cell, which produces various antibodies: IgG, IgM, IgA, and IgE. IgD is generally not considered. So based on the foreign substance, which is non-self, it is decided what will be produced. Then every human body has immune memory. IgM is a recent event. We all know dengue IgM means ongoing active disease. IgG is old event. IgE is basically for skin and nasal allergy. We check Ig when we have a chronic allergy case. And IgA causes nephropathy. And as you've seen in police stations, you have such pictures, or in our TVs, that is immune memory. IgG carries a memory. Like dengue IgG is supposed to be positive for 50 years also. So then There is T lymphocyte, which has special receptors on their surface. B kills bacteria by production of antibodies. T directly kills. So they use special receptors on their surface to identify foreign microbes such as bacteria and viruses. And then usually T cells which are harmful to the body. See, T lymphocytes are using receptors to identify foreign particles, which is non-self, and kill them. There were certain T cells which would destroy our own antigen, and they are generally destroyed by thymus in our early age when immunity builds. The self-attacking T cell that escape the destruction by the thymus are activated by some trigger. What trigger? We don't know yet. Could be some environmental trigger, too much of drug taking. Viral infections and hormones are among the most suspected triggers. Now, what happens? The beta lymphocyte, plasma cell has made all this. The rogue T cell or the T cell which has gone mad, which wants to destruct the body, instructs beta lymphocytes to make antibodies against the particular host tissue or organ. Such antibodies are called autoantibodies. So this gone mad T lymphocyte instruct the B lymphocyte to prepare IgM against the body tissues. As a result of this disrupted central and peripheral tolerance system, which eventually lead to maturation and differentiation of autoantibody generating B lymphocyte into autoantibody releasing plasma cell, autoantibodies are generated, and that is the beginning of an autoimmune disorder. Autoantibodies and B lymphocytes that produce them remain the main clinical indicator of an immunological dysfunction in patients with autoimmune disorders. We need to do certain tests in autoimmune disorders. Recent years have shown that immunological abnormalities are present years before the clinical diagnosis of autoimmune disorder comes in. The first trigger has come maybe 5, 10, 20 years back. The manifestation may be late. Just an example, we don't have to use in practice. Antibodies to glutamic acid decarboxylase 65, protein tyrosine phosphatase receptor type N, and insulin predict by several years the development of type 1 diabetes in asymptomatic first degree relatives. And nowadays, first degree relatives of type 1 diabetics are being tested for all of these. Antibodies to RO and LA are present at least 5 years before the clinical diagnosis of systemic lupus. And antibodies to thyroid peroxidase precede by at least 7 years the clinical diagnosis of Hashimoto thyroiditis. Of course, we at our family practice level do not use all this, but it's better to be aware, because whenever a consultant advises an expensive test, your patient will come to you and say, sir, should I do this? And you should know what is the purpose. ESR, very commonly done. Most non-specific test. Before CRP came into vogue, we used to always write ESR with CBC. RBC is suspended in plasma. We know RBCs are suspended in plasma. They normally repel each other because of the surrounding net negative charge. This is how they are suspended, repelling, not getting adhered. The ESR is a simple, non-specific screening test that indirectly measures the presence of inflammation in the blood. because of the inflammatory substances, these RBCs start getting adherent to each other. They form a rouleau. It reflects the tendency of RBCs to settle more rapidly in face of some disease states, usually because of inflammation leads to an increase in plasma fibrinogen, immunoglobulins, and other acute phase reaction proteins. If there is a change in red cell shape or numbers, that may also affect ESR, like spherocytosis or sickle cell. Up to 60 millimeter at the end of 1 hour. It's not said called per hour. At the end of 1 hour is generally non-specific. Moderate elevation of ESR 70 to 90 at the end of 1 hour. Suspicious of COX. Suspicious only. Please underline indicator only. You cannot start COX treatment for a patient with cough and high ESR. With symptoms and evidence of target organ involvement, some lung, some node, something you have to see. And marked elevation above 100 at the end of 1 hour associated with severe deep tissue infection such as tuberculosis, rheumatoid arthritis, SLE, myeloma, etc. So you need it very high. Then we come to RA test or rheumatoid factor test. When RA is clinically suspected, when you suspect rheumatoid arthritis clinically with small joint pains, early morning stiffness and all, then we check rheumatoid factor. It's an autoantibody of IgM type, most relevant in rheumatoid arthritis. Up to 20% patients remain negative for RF factor or RA test. It's called seronegative rheumatoid arthritis. They will remain negative throughout the course of the disease. So then understand one thing, friends, our clinical approach, our clinical acumen is much more important than RA test positive or negative. Clinical acumen overshadows the labs. Anti-CCP. All the beginning I gave you till now of immunity was to bring down to anti-CCP. It's a new test, relatively new test. CCP stands for cyclic citrullinated peptide autoantibody. IgG type is a relatively new blood test. CCP autoantibodies target healthy tissues in the joints. It's ordered during diagnostic evaluation of a person who may have rheumatoid arthritis, suspected of rheumatoid arthritis. Nowadays, it is asked in addition to RA test. If positive at a moderate to high level, it not only confirms the diagnosis, but also indicates that the patient is at increased risk of damage to the joint and the prognosis is guarded, not very good. In the past, diagnosis relied totally on rheumatoid factor. But does it solve all the problem? No. Around 60 to 80% of people diagnosed with RA test have anti-CCP positive. Those with seronegative RA will also be testing negative for CCP. So negative CCP does not mean it's not RA. The test is more than 90% specific, implying that less than 10% of people who test positive do not meet the clinical criteria for rheumatoid arthritis, American guidelines. Positive anti-CCP, very high chances of RA with corresponding symptoms. Negative anti-CCP with clinical features, consider seronegative rheumatoid arthritis. So friends, wishing you a very, very happy Diwali and no webinar on 16th November because 15th is Bhai Dooj. I think you all will be in a holiday mood. We'll meet on 23rd, and this time I will think of some clinical topic because I feel this may have been little boring. So this also will be shown for 2 days, as it is quite confusing, and Rohit has written from US. Ultra magnesium available sparingly in India. I use this brand for treating night cramps and calf muscles. In Mumbai, it is still available. Thank you, Rohit. That will help people. Rohit was my colleague at GS Medical, initially practicing in India, now settled in US. ANA test, Dr. Anju, when we discuss investigation again, ANA and other things we will discuss. Calcium to be done on empty stomach? Yes. Summarizing ionic calcium and its significance. More than half the calcium, around 45% calcium is in bound form, 45% is in ionic form or freely available form. So if you are doing calcium testing in a suspected acidosis or alkalosis or in a suspected malignancy, then you should always ask for ionic calcium, not total serum calcium. This is the difference. Ionic is like FT3, FT4, TSH, freely available for action in the body. Calcium citrate or calcium carbonate. You can describe, pick up any this thing that you like. Thank you very much. Have a nice festival. Enjoy with your family. Think of all of us. Pray for all of us. And God bless you all.